Today we are going to talk about diagnostic approach, investigation and management of the constipation. First of all, diagnostic approach to constipation. An extensive workup of constipated patient is performed on an outpatient basis and usually occurs after approximately 3 to 6 months of failed medical management. Rectal and perineal examination should be repeated at this point. Now, first of all, structural investigations are very important to exclude organic disease, and these include colonoscopy. It is relatively little in use unless to exclude colonic cancer. Then comes the radiology. It is sometimes useful. First of all, plain abdominal films. These may indicate stool retention, colonic dilatation in megarectum or megacolon. Then comes the barium studies. These may show colonic dilatation in Hirschsprung disease. Number 3rd investigation is rectal biopsy. A full thickness biopsy can be helpful in diagnosing Hirschsprung disease. Next is the functional evaluation. For patient with infrequent defecation, a prospective 2 weeks bowel diary and measurement of the colon transit time by colon transit studies are very useful. Next is anorectal manometry. It is only useful in patients with suspected Hirschsprung disease, and absent rectoanal inhibitory reflux is diagnostic of the Hirschsprung disease by anorectal manometry. Normal anorectal function with outlet obstruction suggests withholding behavior. It is common in the children. Next one is the defecography or defecating proctogram. It is performed if an obstruction is suspected at anal canal level. It may be useful if there is a suspected structural problem, for example rectocele prolapse or intersusception, or to assess functional problem in evacuation. This is done in upright or supine position by barium or MRI respectively. Now we will talk about treatment or management of the constipation. The key to the treating most patients with constipation is correction of dietary deficiencies. This generally involves increasing intake of fiber, increasing intake of fluid, and decreasing the use of constipating agents such as milk products, coffee, tea and alcohol. Now, first of all, we will look at the diet and the role of the fiber. Increasing dietary fiber will increase stool weight, will increase stool frequency in normal people. However, there is no evidence that constipated patients consumes less fiber than non-constipated people. Conventional management is to increase dietary soluble fibers like fruit and vegetables to 20 to 30 gram per day. Bulking effect of fiber is due to water retaining properties. Fiber can also be substrate for colonic bacteria by increasing stool bulk by bacterial proliferation. Fiber supplementation is not indicated in patients with megacolon or megarectum, patients confined to bed, or patients with neurological disease. Now we will see the food sources of the dietary fiber. Food sources of dietary fibers, there are some foods like cereals, whole wheat bread, peanuts, peanut butter, vegetable and fruits. Maximum quantity of the fiber gram per 100 gram is in the cereals, then in the wheat bread, then in peanuts, then peanut butter, vegetables and fruits. Then comes the drug used to relieve patients with constipation. Number 1 category is the bulking agent. Bulking agent increase fecal mass, stimulate peristalsis. These agents include bran, methylcellulose and ispagola. Then are the stimulants. Stimulants include bisacodyl, docusate, picosulfate. Prolonged use can cause atonic, non-functioning colon and hypokalemia. Then next category is the stool softeners like paraffin. They can cause anal seepage and granulomatous reaction. Next one is the osmotic laxatives. They increase water amount in large bowel, and osmotic laxatives are like magnesium hydroxide, phosphate enemas and lactulose. Lactulose is disaccharide. It is not absorbed in the intestine. Next one is glycerine. These are intrarectal enemas. Then lubiprostone and linaclotide are FDA approved medications for chronic idiopathic constipation and constipation caused by the irritable bowel syndrome. Next one is the behavioral treatment of the constipation. They include toilet habit training, psychological support, addressing lifestyle and dietary factors, and biofeedback therapy. At the end, surgery is indicated. Agreed indications are Hirschsprung disease and rectocele.